Welcome. Some of you guys were here last year. I think when this came about partly because I was whining at a wine and cheese about the fact that family medicine, but pretty much medicine in general, tends to be fairly ahistoric, which is many of you who have been in other institutions, organizations, work situations often hear about the beginning of things and what's the history and who are the people that founded it, and it talks a lot about values and about purpose. And so I was talking to Ildi a couple of years ago about the fact that you could do a wildlife, so kind of catch you guys when we can, or should it be a part of the basic curriculum of what it is to be a family physician, and is to understand something about history. And some of you may be just good historical readers on your own, and some of you may be interested in it, and some of you may not. But all I can say is that it's an important part of my life, because I was just telling Mark that I started my residency program in June of 1970. So it's been a while, and it's been surprising how much in the residents at Wingre hear me whine again about how little has changed, actually. So, but a lot has changed. And so one of the things that I thought we'd do is I'll talk a little bit about some of the historical components of it, but the most important thing is you have a person in this department who not only founded this department, but was one of the founders of the discipline. So that in 1969 there were 15 programs in the United States that were approved, 15. Now there are about 540. And Marc Hansen was the founder of the University of Wisconsin program. He was the person who was on the list that I just saw in Kansas City of all of the 15 people who started it. I think I was reading Roger Linke's interview and a few others, but there's not too many people left from that particular group of people. So the opportunity to hear Marc, and you know him from all of the things that we celebrate in this department around his.
Did I get the mute? Yeah, I think you hit it.
You all right?
Oh, there we go.
Okay. And so what I want to do is just kind of start out with those of you who don't know the history of this place, to get a little bit of that from Marc, but also a little bit about what the times were in mid to late 60s, because that's when everything was starting up. So it's an honor and a pleasure to have Dr. Hansen talk with us today.
I think I'm going to sit on a table here. It's easier to see you. I don't recognize John without his beard, so things change over time. When I was in medical school, there was no talk of family medicine in that medical school, and it was my thought at the time that I was going to be a general practitioner. It turns out that's not very practical, because I think you need two hands to be a real general practitioner, but my plan was to spend a year continuing general medicine training, and then come to Wisconsin and take a year of pediatrics, and then go off into Ripon, Wisconsin, which is my selected site as the ideal place. Well, it didn't quite work out that way. I liked pediatrics and was good at it. The Department of Pediatrics had just begun that year that I came, because it had previously been part of the Department of Medicine. So there are some things that change over time. And it was supposed to be the beginning of the sort of the modernization of Wisconsin as a medical school. And I was one of 4 residents that first year. The other 3 were foreign graduates, good doctors, but foreign graduates nonetheless. And we almost functioned as faculty from day one, because there were only a couple faculty. Obviously, I hadn't done a lot of digging to find out about what things were like in Wisconsin before I came here, but it turned out that that was the foundation of my career. The word those days was that you needed a gimmick for academic medicine, and that usually meant being sent to a laboratory. And I went off to the Army, where I saw hundreds of kids a day for several years. So I was glad to come back to something other than that. But it turned out that the scientific world was not where my heart was. So the real foundation of the founding, to the extent that it has a continuity, came when I was sort of abandoning my laboratory, and I had got the job of finding a new leader for the Well Baby clinic, which was about all that the Department of Pediatrics had in the way of clinic education other than sort of the general sort of referral clinic. And I recruited myself, and that led directly to creating the first what would now be called primary care pediatric clinic. And right from the beginning, my goal was to expand that to care for people of all ages and specifically for families. So over the course of a couple of years, this would have been in the 64, 65 range. I added colleagues in medicine and psychiatry and obstetrics and nurse clinicians and therapists, social work therapists. And we called ourselves the University Family Health Service. This was exactly the time that the transition was being made from family medicine, from general practice to family medicine. And we'd been going for a year or two, and it was at the time that Lynn Carmichael, who John's called your attention to, and Lee Blanchard were sent around the country to enlist medical schools in creating family practice training programs. By that time, I'd already realized that my most useful colleagues in the community in terms of sending students out for clinical experience in childcare was actually the family physicians. So I had a community of family physicians that I was in touch with. And Lee Blanchard showed up, and the dean didn't know who to have him see except for me. That was the only thing that was close to what he was looking for. So I entertained Lee that day. He visited us at our clinic. I told him what my thoughts were about how one should be trained for primary care. And I expressed the feeling that we were indeed ready for family medicine in the medical school, at least as far as I was concerned. So he said, well, go ahead and apply on the basis of what you're already doing, and we did, and that's how we got to be one of the first 15. There was another boost at that time. Tommy Thompson, who most of you probably know who he is, former governor and the former secretary of HEW, was then in his first year as a state assemblyman, and he came around and asked the question, what's the medical school doing for the small towns of the state? And the answer was, well, nothing very specific. Wisconsin had always had a preset or a externship program that sent students, still do, I think, to community physicians around the state. So in that sense, it had, from the beginning, been prepared to at least communicate with the community. But that was all that existed at that time, and it wasn't working in terms of getting doctors for small communities. So I met with him. I explained that what we were doing was a practice that would work in communities that were big enough to support multi-specialty groups in primary care, but it wouldn't work in Elroy, which is where he was from. And that in order to do that, we really needed to create a family medicine program, and that I was willing and able to go ahead and do it, but I would need some help. So we got his first year pork. He had one bill that passed that year and was giving $50,000 to the medical school to work on prepare for there being a family medicine department or program. And one of the local doctors, Jerry Darris, came and worked part-time with me that year. And with that money in hand, I approached St. Mary's. I actually approached all the hospitals, but St. Mary's was the only one that was interested, and had had a healthy family practice community within the hospital, and actually had participated in leadership, so it was a fairly natural place to go. The university at that time wasn't interested at all, and the two other hospitals at the time used to be Madison General and Methodist hospitals. They weren't interested either. They were satisfied with their specialty orientation. So we went ahead and began. St. Mary's was not only willing, but they were eager to provide some of the support to get going. The director at that time was Sister Rebecca Wright, and she was certainly one of the in fact founders of the program that you're part of now. So with that, I set about finding a family physician leader for the program, and that's how John Renner was found. He was the first person, one of the few people that actually wrote in when I had ads out. I went to visit John, who was a very colorful person. His practice was unusual. It was in a house in a big lot, and John had a very sort of unstandard team working for me. There were internists who were interested in primary care. There were nurses, and he had I don't think it was a psychiatrist, but a therapist that was part of it. So his ideas of how a practice should be organized corresponded to what I had been doing, and so John was invited to come and be interviewed, and was selected as the first program director. He was an interesting guy. When he moved to Madison, he moved he filled a freight car, train for freight car with the automobiles that he didn't drive out and everything else that he owned in the world. And he, one of the important things, the first things he did was he hired a conscientious objector who was expected to, this was the Vietnam War time, who was expected to find some job in healthcare or something, and hired Tom Hovde to empty his boxcar, and Tom subsequently became the first employee, other than John, of the department. When we started the first clinic was in John's basement, but the second clinic was over where that building is now in what had been the nuns' chapel area, and then it sort of moved over to the other end of the hospital in one of the upstairs, and then finally moved here when this became identified as as where the family medicine program was going to be. So we've been here since 1970. And the first residents came, the first year, John, in his imagination, thought that he would be able to, if he could get the medical school to agree to have students spend their entire year here, that could serve as their first year of training for family medicine, and then they would have 2 more years to go. And wasn't exactly what happened, because we had 2 or 3 medical students, one of whom was also became the first resident the next year, George Gay. And in the second year, there were a couple other people who joined from other programs. I think John Beasley came at that time. And in the next year was the first year in which the match was promoted and filled. And you're the last groups of matches that have come now for over 45, going on 46 years. It's interesting that when you think back to what the problems were in the 60s, they aren't very different from what the problems are now. And you probably have a grasp of the idea that not everybody in the medical school faculty is enthusiastic about family physicians and what we believe your job is. It's interesting that the department provided a lot of leadership in the medical school in the dean's office. There have been, ever since the late 70s, there have been family physicians in the dean's office. The original dean, who was my contact person when we met with Lee Blanchard and Tommy Thompson, was Peter Eichmann, and he was, of all the deans we've had since that time, he was easily the most supportive. He was the son of a general practitioner, and he knew kind of what we were trying to do. So that's the course of the history. The problems you face now are not all that different from the problems we faced back then, being integrated into healthcare in a way that actually utilizes your training effectively, avoids the mishaps of being in the clinic doing piecework as a loss leader for the specialists. So that's how it started.
So the first residents came in 69 or 70?
Well, the first residents were the medical students, and they came in, I think, 71, and in 72 was the first recruitment of actual residents.
So a lot of you all may have, and it's kind of ironic so I was started in 70, so I would have been in the same cohort as those folks, and everybody is retiring. And so I was going to say, at one point in history, 5 years ago, 10 years ago, in the course of being at St. Mary's or being at the U or being in the department, you would have bumped into some folks who would have been from the first cohort. So people like Dan Barry and Cal Bruce, and Beasley still hangs around, so he's kind of has to represent that, but a lot of other people. But now that, we've gone on to be...
One of the things that John Renner did that was most important, and he did it right from the beginning, was to buy into the idea that our job was statewide. And the initial growth of the department was the program here, but within the next several years, programs were created in Eau Claire, Wausau, and Appleton, purposely to be part of the department. And in that sense, we're very different from anything that any of the other departments could even imagine. And they literally were part of our department. There's a complicated further story that we added several other programs. One of them was in Milwaukee because the Milwaukee family's physicians couldn't get any interest or action from the medical college, and so they said, you need to come in here and sort of push them into what they need to do. And so we started a residency in Milwaukee and another one in Waukesha. Quite a bit later, in the late 80s, the medical college fell out with Aurora, or vice versa, and they took over our two programs, and we took over one of their programs, and so that was our life in.
But I mean, the other thing is, and it's still pretty true, I don't know the statistics exactly, but the vast majority of family medicine residency programs, as you all know because you were interviewing for them not all that long ago, are in community hospitals. And so it's always been the case. So when, in a sense, St. Mary's being a community hospital but having the university connection is a little bit of a hybrid. And there are some of those hybrids around, but my first academic job was at UMass in Worcester, and I worked at a city hospital. That's where the residency program was, and there was a university, but it was kind of like Wisconsin. It was not a well-formed hospital and not very functioning. So there's always been this interesting relationship between communities, and then the ones that are farther afield from places like Madison, you know, the Wassaws and the Appletons, and some of those are clearly much more autonomous. But most programs now, over the last 10 years, most community hospital programs have affiliated and have some working relationships with universities. Now, what that actually translates into is always very interesting. So those of you who go out after you finish here and look around for teaching jobs or positions in practice can get connected with teaching programs because they're fairly well around the country. So of the ones in the country, the last time I looked, you know, probably 400 of the 540 are community hospital-based programs, so that's kind of thing.
The other early growth of things were the creation of the 3 and then 4 Madison clinics. I mean, WINGRA was here, down that hall, for quite a few years before it created a building which has subsequently been sort of abandoned in the new building. And the Verona practice was in a house, and they've gone through several iterations of new building. Northeast was in the front of a store, and we were there for several years before the Northeast Clinic was built. Barrett and Belleville was in a house and then became a clinic, and so forth and so on. The original faculty were people used to practicing in those kind of places. They weren't uncomfortable at all in the front of a store or in a house or in the hall.
Yeah, my first clinic was literally a storefront. It was one of these, you know, plate glass windows that we had big shades that went down so you couldn't see me examining patients. You know, and things have moved along. But that'd be interesting to see. I know a lot of those places have been torn down or disappeared, so they probably can't find them anywhere that I can think of. You know, we were driving by the old, what was now the old WINGRA building, which is sadly looks like it's falling apart. But that was the new WINGRA building when I came here in '93, because this was the clinic where WINGRA was happening, and then the big move was there. And so by the time I got here in '93, there were 4 clinics all located in communities. And that, again, was a fairly unusual. Most of the places that, I don't know, when you look around now and look at different programs, the hospital tends to be a place that has an attached building that's the family practice center. One of the things in Wisconsin, which is a really important thing, is that clinics are in communities, and the communities are physical locations where you can define populations and think about. And you all know that, because we have those data and you look at them, is that the populations of each of the clinics is substantially different. You know, not that you're getting totally different experiences, but the populations are different, and that's probably setting the trend for the future.
You have some questions. We've been talking. Is this all new to you, or have you heard of most of it before? I mean, the interesting thing to me is the changing character of the resident experience, and to some extent the people who choose to come here. I think you're the descendants of the original residents who, when they came, realized that part of their job was inventing family medicine. And I think that's still true. I think one of the reasons that as many of our residents have ended up with teaching jobs and expanding the roles of what their training was, et cetera. And it's been a very rich resource, not just for ourselves, but for the country.
And I think that, you know, I was talking to Ildi this morning, and some of you know more about this than I do, about strategic planning and thinking about the future. You know, and my pitch is, as long as I've been here and every other job I've ever been in, is it's up to you to remake something. You're the best authorities on what works and what doesn't work in an educational program. And the other thing is you're the best authorities on having a sense of what's going to be asked of you when you get out of here. So we were just talking, you may want to do whatever is called full service. That's an interesting term these days, but kind of the broad spectrum of clinical work. There's some people we were talking about who, you know, do a fairly narrow spectrum of clinical work. So family medicine has always been about stem cells. You guys are starting to differentiate. Please don't do it until you finish, because we don't really want differentiated people by the time. But the idea is that you will then go on to do things. But one of the things that's your responsibility, sorry about that, is Marc got it started. A bunch of us have been kind of keeping it going. You know, it needs remaking in a substantial way, and it's really going to be your opportunity to do that. The best part about my residency, which I won't tell any more war stories, but it was basically I showed up, and the chair of the department, who was Lynn Carmichael, who was the person who wrote the first piece of work in 1965, right? And I sent that thing around about Lynn. I mean, the thing I keep pointing out is how old were you in 1970?
1970, I was 40.
So family medicine was started by young people, all right? So part of the thing is I keep looking at people like Marc who are always older than me, you know, but thank goodness he's
A lot older.
No. I mean, I'm the oldest guy in the room except when you show up. So part of it is that they're started by young people. I mean, the thing was invented by young people. And so if you see yourselves as being, you know, too young, too inexperienced, you know, that's the history of change, is that it's done by people who are too young to know any better. So you know, and the best line I ever heard from someone was we were talking about generational issues, and Jen DeVos said something like, you keep talking about us not making mistakes, and she said, this is 15 years ago, you know, we won't make your mistakes, we'll make our own. So the basic thing is, we hope you don't make our mistakes, but we hope you make your own, because that's how you're going to learn from those kinds of things. This is a picture many of you have seen. It's from a photo essay in 1948 in Life magazine. It was of a guy named Ernest Sirianni, who was a GP in Kremling, Colorado. Anybody from Colorado? No? Well, I've been to Kremling, and it's an interesting place. It kind of looks like that, actually. And it's this, you know, this really is an archetypal picture. I mean, this is this kind of amazing photo. It shows up all the time, and it was done as a photo series by W. Eugene Smith, who was kind of a great photojournalist. And it's an essay on the family doctor. And if you read the narrative in that essay, 1948 Life magazine, there's this kind of intimation like, what's wrong with this country? We don't have enough GPs. This is still when there are a lot of GPs, but the curve was going like that, you know, and they could see it coming. And the differential, fascinating to see the differential. The average GP in 48 earned $18,000 a year. And the specialty amount was an exact multiple of what family docs compared to specialists are like today. So it's exactly the multiple. So when we say it's the differential between us, it was always the differential in many ways. I went through a logbook of one doc in early 50s. The average house call, the average daily charge was $3. And his total collections, this is his logbook, and his total collections at the end of the day of seeing 25 people was like $85. So, you know, but $85 went a long way in 1950s. So there's a kind of image that we have, and part of it is you carry this image around. You carry around your stories of your personal ancestors. You carry stories of people you've seen, people who've influenced you, you know, people like Marc who actually had the idea that this was important to get going. And so part of, you know, the reason why you have to be a teacher when you leave here, no matter what you do, is you got to pass this kind of stuff on. Yeah. Yeah, I mean, the term, a lot of people who wrote back then about why they chose it was because, you know, there's a very interesting story which is not worth getting into, but the fascinating part is the most difficult group of people to convince that there should be a specialty called family medicine were the GPs. And they rejected it as a motion for the American Academy of General Practice 7 years in a row throughout the entire 60s, pretty much. Towards the end of the 60s, they didn't.
Like, what was the threat to them? Like, what's the threat? What was the threat?
Well, the issue was, as best I can tell, and again, this is just going through the stuff that was available to me, was there was a fear of loss of hospital privileges, that somehow if we call ourselves, the GP surgeons were, I mean, your grandfather was a GP surgeon. I bet somebody, one of your ancestors was a GP. I mean, not, but first assisted, things like that. That was a vital part of two things. One is their identity and the financial stream, because it was, I mean, if you're charging $3 for an office visit, you can get a whole lot more by second assisting on a surgery than you can in an office. So it was a financial issue. It was an access to hospitals, which was a financial issue, because hospitals was where the money was, still is, but it's where the money was. And then the third thing was, I mean, as my reading between the lines and reading letter after letter after letter from people, was that they were just like all of us. Was they were hard-nosed. They were like your grandfather. I mean, completely self-sufficient. They were solo people. They were working their butts off. They knew they were doing a good job, and it felt like they were being told that they weren't good enough. To be a specialist, you have to be a specialist. And of course, they were saying, "Why am I? I'm a specialist as a generalist." But there was another group of people who just kept at it, like Lynn Carmichael and a number of other people like that, who were basically like union organizers going around the country saying, "We got to change this, because if we don't change it, we'll die." Now that was a big roll of the dice, because when Mark started the program, there was a belief that somebody'd come. But there was absolutely no assurance, because GP residency programs existed then. So there's a lot of GP programs. There are probably, I think, something like 60 or 70 GP programs. 2-year internal, basically 2-year rotating internships. That was the training for GPs. And only about, like I said, there were only 60 of them. So most people didn't even do that. They did an internship and then went into practice.
And Gene Farley did one of those.
That's right. So Gene was one of those. A lot of the founders were people who actually didn't take residency programs. They took a little bit, like Gene, they went back and got a master's in public health or things like that, but they didn't do, And family medicine also needed a political identity that said, this is different. So I spent the first bunch of years of my life wasting my time actually saying, I'm not a GP, I'm a family doctor. And people would say, well, so what's the difference? And I had an elevator speech for that, but I didn't believe it. In many ways, the people who were my teachers were GPs and really good ones, and they did a great job. But there was systematic, organized training. You're now in the midst of all that. So you're the recipients of that. But I want to show you something here that's kind of interesting about this whole question of, here's all the different data that I just talked about. So these are the things that had to get going. And actually, if you look at international general practice, these are the things that have to happen every place. Is you got to have a trade union, right? You got to have American Academy is the trade union. It's the guild that you join it. You put your membership in there. They speak for us. They speak for us in front of all sorts of different entities, insurance companies, the government, things like that. Now, the history is that they didn't speak very effectively for us, because we got screwed every time there was healthcare reform. So as soon as Blue Cross came along, we lost that one. Harry Truman came out in '48 saying we got to have a national health system. We lost on that one. They've been on the wrong side of change until recently. And so one of the problems is they'd speak for us, but they wouldn't speak. They'd speak for a lot of people who were like, not blame your grandfather, but there were these kind of crusty, determined, independent, no one speaks for me, I speak for myself, and I don't like the government, type thing. And then when Medicare came along, the reality is physician incomes went up, and nonstop. It's basically going up to 65. It's been nonstop going up.
But the ratio stayed the same.
That's right. The ratio stayed. So we earn more, but they did too, so to speak. You need a trade union. You need, kind of organized educational programs. So that's why I was the residency director group. And you need a certifying body. And this was the biggest fight, was about, do you need a certifying body? Well, whether we need it or not, it was the way that medicine was done and is being done in this country. So now there's certificates of something or other for almost anything you can imagine, which is the way America kind of controls the flow of people into different disciplines. So the American Board came along, and that started in '69. The AAFP went from the AGP to the AAFP in '69. and the first residency programs were accredited in '69. So those were all three things that happened in a single year that was pretty important. And then the Society of Teachers is an organization of academics. But let me show you, oh well, this is two things. One is, I love ancestor pictures. Some of you saw this last year, but these are your ancestors, so to speak. Not here. I wish we had a picture of the first residents here. I can't find one particularly, but so this is Lynn Carmichael, you know, who was like Marc Hansen, about 39, 40 years old. You know, the first person, first president of STFM, the first department that they got going, all that kind of stuff. And those were, this guy actually was my chief resident, believe it or not. And so you can see the technology. This is the technology they had, which was really quite wonderful. And a lot of them, a couple of them were Cuban physician immigrants. So there was still a large percentage of people from international medical graduates in those days. So this is the group of people who got started in '69 in Miami, which is where he was. And this is, I love this picture because it's Gene Farley looking like you know, a Quaker or a Mennonite. I saw him on the train when I was on the train. You know, have this white beard. It's before he put his mustache on. So this is Gene in 1971, I think 72, in Rochester, which is another kind of starter program. And in this picture are people who went on to be deans at the University of Washington, people who went on to be residency directors in Madison. This is John, right?
John, yeah, John, yeah.
So he was a residency director here. There's another person who was the head of family medicine at Duke. So the first group of people went on to do some interesting things, and you had a chance to do it because, you know, I keep saying if you could fog a mirror, you could be a faculty member in those days, and so it was pretty true. So that's Gene in his Quaker days. So this is the thing that started it, and then I'll stop and just talk with questions. There's a thing called the Willard Report, and you want to say why. So one of the questions, you know, Brett, is why are there 3 years? You know why there's 3 years? Why are you doing 3 years of training instead of 2 or 1 or 4 or whatever?
That's what everyone else was doing.
What?
Because that's what everyone else was doing.
Exactly. What a great answer. You knew that already.
Well, I read the article.
Oh, okay. So, you know, the whole point is that you know, everybody else was doing it, so we did it. So the rationale for why are you doing these 3 years of, you know, there's really no rationale. Canadians do 2 years, as you know. They tried to change it to 3 years, and everybody left after 2. So.
And now, like, OHSU is doing.
Yeah, I know. Oregon always tries to do everything differently, you know. So a number of people are talking about 4. A number of people are talking about 3 plus something else. So you could be residents until you're in your mid-50s if you'd like, but I think it's wasting a lot of your time. So this is the original report, which is online, which I'd encourage you to go see. But it's really fascinating to read because was called the blueprint. So the Willard Report, Dr. Willard was the dean at the University of Kentucky. He was tasked with coming up with a report that was going to outline the blueprint for your lives. And this is what they put in the Willard Report. And why it's so important to be involved in this with ILDE and others to redo this program here. Because a lot of it, you know, we think, oh, it was a prescribed regimen. It wasn't, actually. We did it to ourselves. So this is the things you should have been doing, right? Those all look pretty familiar. Integration, knowledge of resources, knowledge of communities. These are principles. These are not rules. These are principles. So what you're supposed to do is take principles and implement them where you are. So comprehensive medical care. The behavioral sciences is one of the things that, you know, Marc mentioned. Kind of one of the people that was with them was a behavioral health educator, you know, clinical social worker stuff. So we're doing this brand new thing at our clinics in Winger and places with the integrated. That was actually happening 50 years ago or more. So it's an idea that has been around for a long time. We lost it, and now it's kind of back in some way. You know, the Model Family Practice Center, and I keep pointing out to people, before 1969, with a few exceptions, there was no training in communities. GPs didn't train in communities. Nobody trained in communities. Nobody trained outside of a hospital. So anybody whose parents are physicians, all trained in hospitals. Well, your parents are probably young enough to be my kids, so I want to be a little careful about this. But people who are in their 60s and 70s all trained in hospitals. So part of it is that the Model Family Practice Center was a really big deal, very big deal. And I'm sure that the controversies about training people in communities or in this building or something was really quite a, like, why would you want to leave the hospital? It's the same thing you guys go through now. When you're under a hospital rotation, what's your priority? The priority is the hospital often. And I'm not dinging that particularly, but it is this conflict, and it's been there forever. Success requires other major clinical departments being supportive. That's still forthcoming, and some places are better than others. And that the idea that it should be a department or program, that was a new thing. This was written in 1965. Okay, these principles were. But the most important one is this one, and I want you to pay close attention to this one, because this is the last one. And so it says, the guidelines for family practice educational programs must permit substantial flexibility and freedom in content and organization, since there are virtually no models today to serve as patterns. The needs, conditions, and resources of communities vary greatly, as do the interests of young physicians and the type and scope of their practices. These factors emphasize the necessity for flexibility in programs. If they're to meet the needs of society, rigid standardization should be avoided. Now, when I show that to residency directors, it's always a shock, because this was the document that was supposed to say, here's, A, B, C, sub C. So you guys have looked at your curriculum. Your curriculum says 4 hours of this, 3 hours of that, and 12 hours of that. That's not what they were saying. They were saying that every community and every educational system is different from others, and so it needs to adapt to whatever is there, not be rigid. But this is important for me, because when I read this, I thought, are you kidding? After dealing with the residency review committee and dealing with all of the people who come in, you're getting subjected to more and more and more compliance. So we're all about compliance now. I'm pretty sure you're going to get good educations, and I'm pretty sure you would do a lot of that yourselves and not rely on people like us to do that kind of stuff. But the reality is we don't trust each other enough to be able to say, go ahead and create it as you go along. So maybe the challenge, and if you want to use a document, a 50, how old is that, 65? 55-year-old or 60-year-old document, to say we should do flexibility, avoid rigidity, and create things that make sense for us. You have, a very long history. This is like the Constitution. And if you want, you can say Marc is like George Washington, and you can bring Marc in and he can validate that particular point. So that's an important thing to keep in mind, is your curriculum is not set up by those people who founded it, because they didn't know what they were doing in the sense of specifics. They said, go find the best way to do it and do it yourselves. So as you go forward in your lives and do something around education, you have a model and a way to be able to think about that. Now I'm going to skip a number of things.
Does
There's
that
some.
account for ACGME at the time?
Sorry?
Does that account for ACGME?
Counts for, well, what we did is we set up a bureaucracy, because America's about certification, and it's a compliance-oriented, it's HIPAA, it's this, it's that. It's the fact that we probably have behaved so badly that we can't trust each other, But if you trust people to do the right thing, they should do the right thing. But I'm not saying that that's probably ever going to happen again, but you can break out of a mold and do something different if you'd like to.
One of the things you haven't emphasized, which I think is important, is that for the practices of your grandparents and so forth, they wouldn't have seen them as businesses. I mean, they had to make their living that way. But the commercialization and the income machine, I mean, we're part of a medical industrial complex that is not that much more healthy than the military industrial complex, and it's changing your lives or trying to control your lives. And so that will be a factor of your reality, which you'll struggle with for whatever.
I mean, the reality is that in this country, I think in the state of Wisconsin, 85% of the new physicians are employed. And nationally, I'm not sure what the numbers are, but it's certainly a majority of people are employed. That isn't necessarily a bad thing at all, obviously. It gives you a lot of stability. It gives you things that, I was reading through, so if you look at what your grandfather did to retire, he had to sell his practice. That was his equity, right? So basically, why a lot of old GPs didn't retire, it's because they didn't have any equity. They didn't have any retirement funds. Social Security had barely come into existence. And so they had to figure out a way. So there's a lot of things when you get deeper into it about why people sold their practices to big systems, why when I got here the Physicians Plus group was a bunch of medium-sized practices that said if we don't figure out how to get together, we're going to go down in flames. And so they created this group. And in this country we've talked about this, there are cultural groups. Mayo Clinic's a cultural group. Dean tends to be more of a cultural group. Those are groups, Marshfield as examples. Those are cultures. You enter those cultures, you take the pledge, you know what you're going to do, and it doesn't mean it's bad, it just means it's a culture that's clear. People like P+, UW Health, Aurora, all those are not cultures. They're lifeboat groups. I mean, they got together because they needed to from a financial point of view. Are you frowning because you're having contractions, or are
No,
you?
I'm just
Okay,
thinking
good.
about what you're saying
Uh,
about, like say Dean's a cultural group versus UW not being a cultural group.
UW is not a cultural group.
And I just
We're trying to be one, but the problem is if you look at the literature on anthropology or anything about cultures, is it takes a period of standardization before you can start to have decentralization. So UW, having been here, and you've been here Marc was actually the head of what's now called Unity. So he was the medical director of Unity when I first got here. UCare, right?
It was actually one of the high points of my medical life. It was an accident that I became I was the vice president of UCare, which is a non-job, and the president resigned with another physician, and I was the vice president, so I became the president. And this was at the very beginning of it was early in the HMO days, and the medical faculty thought that it was not a very good idea to have an HMO, and if they had one, its ideal size should be 0. But they had one, and what I managed to do was to get, using the model of group health or any of the big practices that take care of populations, they had an idea of what every subspecialty ought to get as part of the healthcare dollar that they were raising and responsible for. And I managed to capitate all the departments, the hospital, and the advantage to me was that I used the group health percentages for what share of the healthcare dollar ought to go to primary care. And it's the only time in the 50 or 60 years I've been around here that, I mean, this was a minority part of the income of the department, but it was enough that was the only time the department had secure financial basis. They were getting paid for what they should be paid to do what they do. And as soon as UCare was sold because the faculty had decided that the ideal size had become infinite, and that the way they were going to accomplish this was sell UCare to Blue Cross. Blue Cross bought HMO Wisconsin, and HMO Wisconsin and UCare became Unity. And nothing much changed. The university thought they were going to get all this business from the rural practices that they weren't getting, and now they were supposed to get it. Well, that didn't change much. And a few years later, WellPoint, a big HMO, mainly on the West Coast, came in and wanted to get a foot in the door of Wisconsin and Dane County. So the medical school, hospital, and doctors ended up having to buy back the HMO, which became Unity.
So I mean, this is in HMOs, you haven't been around for that era, but HMOs used to mean basically that most people, like Marc was talking about, were capitated. So in other words, it wasn't piecework, it was a way of paying you, saying per member per month and all that kind of stuff. You probably read about some of that in your life. But it was a much more secure, you knew how much money, it's like running a family with a budget that you know what you're going to earn every month, as opposed to, if it's a good month, we see a lot of people. If it's a bad month, we don't see a lot of people. And that's still the trap that we're in, and it's something that people have written about. The New York Times, New England Journal, everybody writes about it, but nobody is doing anything about it. It's beginning to change now with Medicare, making some arrangements so that you can have capitation again for different systems, what it's going to take.
When UCare was sold, it took weeks, hardly months, for the entire system to go back to a fee-for-service basis, and so the idea was that everybody should get the same percentage of their fees back, whether you're doing neurosurgery or family practice, and obviously that's when family practice sort of became difficult to support again.
So what other thoughts do you guys have? I mean, you got here by some kind of personal history and by being exposed to people who had some influences on your thinking and stuff. What about history in terms of our discipline have you heard or think are important? Yes?
I'm just curious to hear from both of you about, as we think about things that we think need to be worked on and changed and improved in the system, what have your experiences been about the most effective ways that change happened? Was it through, brilliant leadership or collaboration or organization, or what were the really effective tools that you'd like us to take from you and use?
Well, I think that the whole issue of the idea of capitation is that there isn't any inherent reason why one should be paid 4 or 5 times as much to do one's medical work as you are paid to do your medical work. There's nothing wrong with there being some differential, but it's outrageous at the present time. And most of medicine is supposed to be non-profit, but they have to scramble to spend their non-profit on new buildings, fancier facilities, et cetera, hiring more unusual instruments and people. So there's another period which we haven't mentioned at all that lasted during the 60s, really, of health planning. There were health planning agencies in all the states. There was an active one in Wisconsin, and they were all working in the direction of trying to sort of bring the system under some rational guidelines that would begin to control costs, to not overbill, to not do all that sort of thing. That was all abandoned, completely gone.
But I think that, so if you go, there's this article I didn't allude to, but I think it would be really important for all of you to read, that Gail Stevens, who was one of the most important writers in anybody's field, wrote, called Family Medicine as Counterculture. And part of it about that is that the reason, and Mark alluded to this, the reason that this department came to be, the reason that family medicine came to be is because we worked in real close alliance with the people we serve. So the level of change didn't come about because medical schools had a light bulb going on, so we should do something about primary care. We did it because communities demanded it, because we were responsive to those communities. And I think one of the things that's eroded, in my personal opinion, in a lot of organizations, especially as you get bigger, is you see the level of change at being at Unity or being at UW Health or sitting on yet another committee. Now, I've sat on a lot of committees in my life, and I think you try to make change and you don't kind of give up on that. But the place that really has the power are the people who are using the services. And so, one of the things that we don't do anymore, which I'm sure Mark did and I certainly did when I was here, or when I am still here some, is go knock on doors of legislators. I mean, Tommy Thompson was a Republican legislator from a rural district. He wasn't a flaming liberal from the east side of Madison, right? So, but we wanted the same things. And when we have the Wisconsin Idea Award, which we give, and Tommy was the first recipient of it, and what's fascinating is he said the thing he's proudest of in his legislative career, which is a pretty big legislative career, was the creation of the Department of Family Medicine, because it was the most direct service to the people he came from. So part of it is the way to change is to make alliances, and the alliances are with people and communities and forces, social forces. So when Gail wrote about that, it was feminism, it was consumerism, it was agrarianism. So agrarianism still, small towns have a lot of power in this. You guys in Baraboo, you're going to make the future for all of us. So get out there and meet your legislators and talk to your local folks. And so that's my belief is, and you know, I come from a history personally of community organizing in Chicago. You know, I'm very empathetic with the president because I was doing that. And so part of it is you work at the level and you work your way till you get enough people to start making some changes. I mean, it's a fairly simplistic way to think about it, but I really do think that, I mean, if you think, I was talking to somebody recently about an article I read in Science this last month about how did climate change go from being a marginal political discussion 15 or 20 years ago, right, to the fact that all the leaders of the world are meeting in Paris to talk about climate change as something they have to pay attention. How did that happen? You know, it didn't happen by people in Kyoto saying we have to decrease the amount. I mean, declarations at national levels aren't worth squat, actually. But people working at local levels, making a difference, making alliances, making change, convincing people who need to be convinced, working on all that is where it happens. And so if you know, you got to work at both levels. I think the whole idea is you got to work. It's the old line about think globally, act locally, which is true. But if we're going to remake care for the people in the United States, we have to talk to the people in the United States. We have to visit with the people in our United States, our patients, you know. And right now, unfortunately, what's happened is with the large institutions coming along, your kind of mindset is, how in the hell can I change UW Health? And the answer is, not very easily, but you sure can change what's going on in, which clinic are you at? Okay, well, you know, you guys are doing some interesting things at Verona. You're knocking on doors, you meet with the mayor, you know, those are the people. And those folks will get to whoever needs to be gotten to make a difference. And so the way to make change for me has always been working at the level it's the most familiar and where you have the most credibility, which is your community and your neighborhood.
I don't know what you individually or group-wise think of the Affordable Care Act, but its bad press and the vitriolic attacks on it are way out of proportion to what it signified and accomplished. The most important thing that happened when it was passed was we began to agree that everybody should have health care. And there were all kinds of compromises that are really what people are bothered by that had to be made to pass it at all. But I mean, that was a step forward, and it's a great risk.
And the year I started medical school was when Medicare started. So, you know, you think there haven't been some fixes on Medicare for the last, 60 years or so? So yeah, I mean, fix it. Make it work right, you know. That's where some of the, your question about change, that's some of the places that you can actually sit down with people and say, this part doesn't work for us trying to deliver care in this kind of community. Can you look at a way to make that better? And I know from people who've been in politics that they need to hear from people who are on the ground doing this stuff. So yeah, I mean, I've been living my whole life. I remember when if you have a chance, there's a group. So Tom Petrie and Dave Obey are going around the state. I don't know if you know who either of those people are, but Dave Obey is a pretty amazing person. He gavelled the Affordable Care Act. Pretty amazing. So they're going around the state making some speeches about politics. So go hear what they have to say. But that's a pretty historic kind of thing to be able to do. So it's been a long time waiting for that to happen. And it's, God knows, far from perfect. And the idea we say, well, we only have, 18 million people uninsured now? Only 18 million? Canada only has 32 million people in total. So the reality is we got a long way to go. But again, that's going to be part of your responsibility. And the stronger the ACA is, and the more it speaks to covering everybody, like Mark says, the more likely it is to be working for our benefit.
Well, the stronger that primary care is.
Yeah.
I mean, primary care is a beneficiary of the affordability of care for all people.
It'll get there. I know you got to come talk, so.
Thanks for giving me a job.
Huh? That's all right.
This guy hired me.
Well, best things they ever did. So, okay, thank you all.
To wrap up.
No, that's okay. So I want to thank Marc for being here. He's coming. Marc, every time I turn around, Marc is coming back from something else. I mean, he's indestructible. And fortunately, you know, he's been not just a part of this department, a part of this state, and a part of this field for, you know, I keep pointing out to people, not only did Marc start one of the first 15 programs, he had an article in the first publication that was ever in family medicine, which was called Journal of Family Practice in 1974, which was the first, 75, which was the first journal that ever came out with our thing. So not only is he a person of action, but he's a person of words and ideas. So thank you very much for coming, Marc. All right.